a final panel to discuss what are we taking home on messages. So we have four distinguished panelists, and the first one, who is Ajay Mahal, who's right next to me. He's going to give some reflections on monitoring, and that's the only slides we're going to use. The next 10 minutes, Ajay has the floor. Ajay is a professor of health systems and economics at the University of Melbourne's Nossal Institute of Global Health. So you have 10 minutes, and then we're going to invite the panel up to give your personal reflections, and you will have time in the next 60 minutes to come with some protests, some additional comments. Few, limited, and very focused. Ajay, 10 minutes.
Let's get cracking. A story about evaluation in Andhra Pradesh. 2007, I arrive flying from Boston. I reach the office of the Chief Secretary of Andhra Pradesh, and I ask, I'm here to evaluate your brand new scheme that you've announced, the Arogacity scheme. He said, meet my PS. He says, fantastic, Ajay, great idea. Let's spend some time chatting about it. The upshot of it was, he said, Ajay, not a good idea to do it right now. I said, if not now, when? You're going to start the scheme in 2 months. He says, we have elections due next May. It's 7 months from now, and who knows, you academics, you might come out with something negative. I said, impossible. He said, it's a $200,000 almost virtual transfer. You can't go wrong with it. He said, no, we still don't trust you. Come back in May after the elections. Okay. I come back in May 2008. Elections are over. If you recall, YSR Rajshekar Reddy had won a landslide. He literally won all the seats. I met the PS again. He was still there. I said, Ajay, glad you could make it, but you're too late. I said, what happened? He said, the evaluation's already been done. I said, by whom? He said, by the people of Andhra Pradesh. All done. Taken care of. The evaluation's done. I also figured out they had done a hatchet job with an internal evaluation done by their friends in a secret report done for the Department of Health in Andhra Pradesh. I smuggled it out. It was full of good things about the Arogacity scheme. I then spent, okay, fine, maybe I can't do this. Maybe I can help them think about the financial implications of this scheme. They said, no, not a good idea. It's going to be perfectly profitable, no problem, no losses, whatever. Fast forward to 2010. In 2010, I heard through a third, fourth hand the following discussion between the head of Arogacity scheme in Andhra Pradesh and the planning minister, the ex-Monte Ahluwalia. And here's how the conversation went. He said, Mr. Minister, we need some money. We're running into difficulties with Arogacity scheme. He said, did you ask me before you started the scheme? No. Come back with an evaluation. And by the way, come back with a good evaluation, because thanks to you, 4 other states have begun this scheme. Okay, that's the history of this. So with those words, what did I learn from that exchange and from that smuggling of documents that I did? That first of all, program outcomes often need to be comparable across contexts, whether or not we want to fix context to the whole discussion. Because even the program's outcomes are context specific, resources most certainly are fungible. They can go across programs, across states, across settings. The second thing, accountability is not just a concern of doctors, nurses, delivery people. It's also a concern of program designers and implementers. We can't ignore their accountability, and evaluation is an important part of that accountability. You shouldn't be allowed to come up with bad programs all the time. Arogacity is not so bad after all with hindsight, but that's... now, post-program implementation evaluation is a serious risk. Once the program had begun, it made no sense for the ministry to then go out and find out that it's a bad thing. So you have an internal evaluation. So there is always a risk that once the program gets implemented, the interests are just too strong to make sure it looks good. You got to commit before you get into it. And finally, it's pretty obvious that political and implementer goals may well differ from the goals of a funder, the finance ministry, or in this case, the planning ministry. That's the lesson that's often important. When you think about evaluation, all of these issues are quite important. And in fact, I would say in a world of limited resources, we can't ignore the importance of evaluation, good evaluation. What do I think are the essentials of a good evaluation? This is not a lecture on evaluation methods, but I want to give you a sense of what are the basic minimum things you ought to be doing in any evaluation. First, please plan your evaluation before you implement the program itself. It's a terrible idea to then wait and figure out how you're going to evaluate, because you're basically rigging the system. You need to have some sort of theoretical framework, some idea about what's driving these outcomes. After all, you wouldn't have had the program in the first place. So there has to be some theoretical grounding, some way to assess the program, what I call testable hypotheses, something to that extent. How should you gather data? Well, at the very minimum, forget about the fancy stuff that the Better Birth program has done. Let's forget that level of high-class stuff. But let's talk about very basic things. What should you be doing? You should certainly have outcome measures that could be compared, replicated, and done by other people in other settings. Remember, despite all the context, you still might want to compare programs in a world of limited resources. Be prepared for unexpected outcomes. You might find that your main goal has fallen short, but other benefits have occurred which weren't planned for. Therefore, you have to have them in your theory at some point as well. Try to make sure to the extent that you can, and this partly reflects my statistical training, have some control somewhere. Ideally, controls that are not too different. You can't compare India with the state of Kansas, but certainly some control that looks similar and reasonably matchable, as it were, to the intervention group. You don't have to go into an RCT. Some baseline prior to the intervention data collection, and some after, perhaps for treatment and controls. And please pay close attention to sampling strategy, sampling size, and a whole range of statistical issues that arise. For example, Manoj mentioned in passing clustering and so forth. So all of these are important elements of a legitimate quantitative evaluation exercise. And as we are learning from our comparative assessment, looking at the analyses done for the different nurse mentoring programs, we realize that no heavy-duty statistical exercise can totally replace a deeper understanding of these programs. So at some level, I would also argue that one has to accompany quantitative work with good qualitative research, which probably involves some mix, and I'm not an expert in qualitative research by any means, but I have colleagues who are really good at it. Certainly, things that involve tracing how the program gets implemented, process evaluation, figuring out, perhaps through a range of conversations with a range of different players to avoid all sorts of biases, to get a sense of how is the program working, who's benefiting, why is it being effective? Because those dummy variables that you have in your regression equations won't really give you those answers. Having decided that this is something you want to do, I think I would support, at the very minimum, this sort of activity. I also been listening very carefully for the past couple of days as to what the big challenges are in quality of care. So where might we apply our evaluations tool to? I have a bunch of ideas. They are not intended to cover the entire gamut of topics discussed, but these are the topics I felt very strongly about, and I thought I'll divide them into three broad areas. Providers of services, public providers. The second one, consumers of services. And the third one, which I refer to as health system issues, including the role of other players, which I call private providers. The one thing that came through in the many discussions was the role of innovators, disruptors, in doing things differently and improving services. I think I recall Geeta making a fairly pertinent point. Innovators do not make large-scale changes. They typically, at the facility level, they do the changes. Perhaps they even get shipped out because other people don't like them. Better still, they leave for the private sector after a while because they're so smart and so clever and innovative. There is always that risk. So you have to ask, well, the obvious thing to ask, if innovators are so important in a system, and they could very well be, because that's what the sense I had, well, it will be interesting to see where do the innovators end up once they make change. What happens to their innovations and why? And do we have good examples, actually, from anywhere in India, other states, elsewhere, of innovations being taken to scale, and what can we learn from these experiences? I'm sure there are many such experiences in India, just that I'm not familiar with them in the MCH world, simply because I'm not an expert in the MCH area. The second individual, or if you like groups of individuals I want to target, is the patient Indian or the consumer. If you look at Amartya Sen and I think Jean Drèze's book about the patient, not the angry one, the patient one, who never complains. Manoj and I were talking earlier today, and I said, well, Manoj, what is it that we don't know about this area? And he said, well, we don't know how much consumers value quality. And because quality had many dimensions, we also don't know how consumers trade off one dimension of quality against another dimension of quality. So certainly we'd like to know a little more about that. Why do we want to know more about that? Because I think if you're going to be talking about accountability mechanisms and so forth, and what consumers want, well, that's a good way to know, because we'll have many dimensions to play with. And going back to, I think, Geeta's again, this issue about the role of existing inequalities in influencing other inequalities. I think it's also important that we understand how socioeconomic inequalities affect consumer demand for quality, as well as their interactions, which of course depend on the demand in the facilities. So I would say focus on the consumer, certainly. These are some of the ideas. Certainly focus on the provider as well, because that's what people seem to believe is very important. But also there are broader health system issues. Yeah, no problem. This is my last slide. We know from the JSY experience that incentives are not totally irrelevant. They did make a shift. They helped make a shift from the private sector to the public sector, a fairly large shift. It wasn't, well, you could argue that nothing happened once they moved to the public sector because the quality wasn't good enough. But nonetheless, there was a shift. Incentives did matter. If that's the case, why don't we think about making organizational and financial change, well, small, maybe tinkering, in the public sector? Because that hasn't happened. What all we've done is talked about this move here. But what about changes within the public sector? Has it been done? If there are examples of that, it's worth looking at those examples. If not, why not think about some moderate level of change, reforms, pilots in the public sector and assess them? I was also a little bit surprised not to hear too much about the functioning of the private sector. Yes, there were some points made, but really not a significant engagement with the private sector. So I think there might be a role to play for research that looks at direct intervention in quality in the private sector, or through financial reforms that involve, for example, purchasing services from the private sector. I'll stop here. Thank you very much. I hope that was 10 minutes.
Ajay, thanks for kicking us off. Please have a seat. Thank you so much. Let me call also three other distinguished panelists. Deepa Nagchowdhury. Deepa, where do I have you? Thank you. Deepa is Deputy Director at the MacArthur Foundation. Next, Subroto Mondal, please. Subroto is MLE person at USAID India. And finally, Kasonda Mwinga. And Kasonda, who's a pediatrician, is a team leader for MNCH Reproductive Health at WHO office here in India, and has actually a quite big portfolio. So what we thought we would do is reflect. This has been an exciting couple of days. Very exciting, and for me personally, encouraging and inspiring. I'm very, very happy to have been part of this workshop. But from your perspective, from the perspective of your four organizations, the Nossal Institute, the MacArthur, USAID, WHO, how do you see the main ideas that you go home with? We go home with different things, but you all go home with, you know, your personal things. So I ask the four people here to think through, what are you going home with? And I thought we would take one idea at a time, have our friends present my main message, your main messages, your four main take-home messages, and then discuss them one by one. So rather than, you know, have everybody do their thing, we'll just take an idea and discuss it a little while. And if you have some protest or some very burning things that you would like to add to that particular idea, flag up. I think I will actually start with Deepa. Deepa, what is your main take-home message or question? What will keep you sleepless a couple of nights?
You know, a little bit about the MacArthur Foundation. We've been funding work on maternal health in India, in Nigeria, and the US, some global work for the past almost 20 years. And yes, the whole issue of quality has, has been brought to the forefront now. But in a way, we've been working around quality of care issues for a fairly long time. And I've been hearing all the presentations, and to some extent, we have been supporting similar kind of work around nurse mentoring, around building capacity of providers, etc., for a very long time. And I've been to various facilities, and it seems to me that we achieve quality up to a point when there is someone external coming in and supervising, mentoring periodically. We are not very sure about outcomes. what happens at the end of it, do we have reduced perinatal deaths, etc. But it also seems that there are champions within these facilities that we institute quality of care improvement. My bigger question is, and I'm pondering this because this has been going on for such a long time, is that how are we ever going to institutionalize a system where quality improvement is kind of integrated within the health system itself, not just facilities, but within the health system, and so that we don't have to repeatedly do this training, mentoring, etc., of externally. So I'd like to hear what thoughts others have, because it's, I personally, within our institution, and when we compare programs, I find it a little bit hard to come up with things. I know from my side, it would be great if we could have third-party quality assurance. I think we are a little bit far away from that. A lot of it is internal, and let's really help out the nurses and improve, and relative, it's all very relative, and context matters. But I'd like to really see where we move from here.
So the question, if I, just correct me if I understood this right, the question is, how can we reach sustainable process that keep going even when the donors and this earmarked money has stopped coming? So how do we reach sustainable processes? Is that correct? Thank you, Deepa, for formulating that main worry of yours. So I would then like to ask the three of you, how do you see this? What are your reflections to Deepa's main concern after these 2 days?
I also share Deepa's thoughts. She's talking about work that they've been doing for MacArthur over a long period of years, but I also see it in WHO's support to different member states, and this happens not just here in India, but also in other areas where the sustainability of these good quality improvement efforts tend to disappear after some time. And for me, one of the main issues is the health system changes only being there for a season, that when a very good program comes in, be it nurse mentoring or whatever intervention comes in, the health system itself is not adapted to change in a way that after this program is closed 3-4 years, it continues. So in my previous region, which was the African region with 47 countries, you actually had issues of what we would term islands of excellence amid rivers of poverty, because the system remains the same, but something is done just to support the system. So I think we need to put efforts in advocating with the member states and the different governments that as we get innovative ideas, the government takes them on board and makes the required health system changes that would be sustainable beyond the project terms.
Coming from USAID's perspective on it, is like we also carry the same sentiment, like when funding agency is funding, but then at that time we see a problem and fix the problem. We very rarely see from public health perspective how as a system as a whole it is responding or actually progressing towards improvement of quality of care. So that's how I think probably there is no measurement as such in a summative level in that way. So our measurement actually either in a very specific area or a very specific level. So as a public health as a whole, we don't see the progress and monitor the progress of quality of care improvement. So that's how I think we need to think about some measurement. And I was thinking that in this entire domain of quality of care, one is the recipient, another is provider. Provider is the system. And then the persons are representative of the system. So different ANMs, doctors, and everybody is representative of the system. Can we think of some ideas of measurement like is always unidirectional and see the better quality of care as I received today compared to yesterday as a recipient, and then also ask the similar question in a little different way to the providers in that particular facility, in particular place or particular area, that if you as a person is not there in the facility, do you feel to send your own family members to the facility? That's how probably we think probably that some providers will reflect on that, yes, they have their own understanding of quality of care, what they are providing to others. So that's how I think we always see that this quality of care is not for me, for others. So can we think of some measures in combining these two so that we always see that betterment of care is being provided and somebody is, and because it is relative, it is not, I see quality of care in different perspective and somebody is in different perspective. So measurement, I think, need to be a little bit different.
Thank you. So let me press you a little bit. What I hear from you, Kasonda, is leadership and inter-country collaboration. What I hear from you, Subruto, is well, that it's different, but it needs to be measured, and people perceive quality in different ways. You're speaking somehow of the demand side. You are also speaking again of the measurement, and that kind of links back to what Ajay was saying, which kind of has been mentioned here. If you can't measure it, you can't improve it. Is that what you have on mind, or you have other thoughts around this?
Actually, I have other thoughts, and my thought was when I heard Deepa talking about how to sustain. Having been part of a report which is sitting on the shelf of the government, the Ministry of Health somewhere, and having seen other reports land up on these shelves, it's always sort of bothered me that how does one get a demander of, the government to demand improvement? The government is not an individual, but a bunch of people. If it doesn't do its job, essentially, I worry that we will ultimately see the private sector taking over even that space that we already have ongoing. So I think one challenge that we have is to sort of see, are there ways we can learn from within India, certainly from within India, I would argue, where we have seen good cases of programs being integrated. Don't we have some success stories? There have to be. I think I'm worried that that a hands-up sort of approach toward this sort of an issue is quite problematic in the longer run. So I would this suggests to me at least that I would be looking for examples and perhaps more investigation of how programs get integrated into the government system and how does innovation make its way in that system. So that's sort of the thought that comes to mind.
So what do you think of the role of standards and having standards that are known and that are real standards, not just in a book, but something that you have the reason to expect and that there's public education along these standards? It has been mentioned here that this is what you have the right to. This is what White Ribbon does, as has been mentioned, that this is what you have the right to, this is what you should ask for, this is what you demand. Do you think that's the way, one of the ways to go, to really hold the authorities accountable, either public or actually also private if there's public investment in? This is what you should ask for. This is the minimum. What do you think?
I think having standards is one of the ways that you can have this improved, but I also feel that the measures of what happens when the standards are not kept is something that you need to go further on. You've mentioned having standards in documents and books, or also you can have the standards, the patients know what they are entitled to, the health workers know what they are entitled to, But in situations, for me personally, where there is no consequence of the standards not being met, then you may still go back to having it on the books, whether people are trained or informed. So the accountability issue, and some of it may also relate to regulation.
Thank you. Let's move on to the next concern of yours in the panel. We've discussed sustainability. There's much more to be said, but we want to keep you awake and on your toes a little bit longer. Kasonde, what's your main takeaway from a WHO perspective? What do you think most of as you go home later today?
One thing which I'm preoccupied with as we talk about improving quality of care is the human beings who are giving the care, particularly around the time of birth. And I'm talking mainly about midwifery practices, the nurses who have to be there to deliver women, and other interventions, including family planning. Looking at the work that WHO has been trying to do in supporting improving midwifery practices, I remember seeing a table of like 11 different courses, or I don't know if some are workshops or courses, but something to do with improving already qualified nurses to improve their skills and competences to get them to global standard or to improve them. And so what makes me worry is continuing with pre-service education that may be leading to a certain quality of staff, but you continue and then continue a lot of investment in the short-term courses during the in-service training. So I would be looking at, have we defined the problem of the skills and competences of the people we're training, the different cadres, whether it's ANMs, GNMs, or BSc nurses as relates to midwifery practices, and have we identified what the problem is in public sector, private sector as well, but what are we doing about pre-service training? And for me, it's also a sustainability issue if you're trying to keep the skills and standards at a certain level.
Thank you, Kasonde. So am I understanding that right, that you're concerned about the practices around birth, that we have to try to get them right and define them? What are the main gaps, priority gaps, and start addressing them systematically in pre-service as at the same time continue in service? Something like that. Any comments from our distinguished panel?
I also...
Closer with mic.
I also, in connection with that, in USAID, we put a lot of investment on different areas of quality of care. We see quality of care can be improved, like pre-service training, in-service training, and then capacity building of different cadres, different ways. Since yesterday, we are learning many things, nurse mentoring, and many dimensions of quality of care. I think I would expect one thing, that if we can prepare a kind of, or bucket it, the gaps in quality of care, and then how in different areas these can be fixed. Probably that will be a good learning from us, that, okay, so what I have to do in pre-service training, what I have to do in service capacity building, what I have to do with the community. So then we have different programs, different mechanism we can think of. Apart from that, one more reflection from learning from last 2 days. Lot of good learning, top quality research people here. Just if I take for a few seconds my hat of USAID. Earlier before joining USAID, I was leading Bihar OPM-led evaluation. So I was mentoring Mayra, who presented that methodology on measuring respectful maternity care. The idea was not surfacing the problem. We knew there are problems. But also to understand the extent of problem, and also to understand, is this behavior different for different people? So then our intervention would be different. So I expect that researcher actually come out those kind of disaggregated findings that, okay, so there are behavior for different people differently. So then we have to think of different intervention for behavior change. I think those kind of things, some in-depth analysis would be helpful. And I'm selfish that I'm asking for those kind of analysis. This is already in the data.
So are you thinking of, I mean, the correct behavior is the correct behavior, but are you saying that we must explore more why the behavior is wrong, like the kind of stuff that Surgo and other qualitative research does, that we need to understand that this provider didn't have lunch or didn't get pay for the last year, while the other one is lacking the resources? Is that the kind of
probably
tailored approach?
Probably the perception was in the context of Bihar. So there are a lot of perception on Dalit, Mahadalit, different caste, and people perceive that providers behave differently with different caste people and different poor socioeconomic conditions. Aparajita mentioned that there exists some anecdotal evidence, but I think that this nurse mentoring data set on respectful maternity care has a potential to surface those type of differential behaviors from the study.
Thanks a lot. So that goes back to what Geeta Sen said. I forget, the expression was too complicated for me, but basically understanding the deficiencies in a much more multifactorial way. What was the word? Intersectionality. It was not only the gender and the poverty and the caste and the ethnic group. It was, you had to understand it much more broadly and deeply so that you could target if there was discrimination in this. Thank you. Any final comment on this one? Concerns that's emanating from Kasonda's theme of getting care around birth reaching minimum standards?
Well, I just have a related comment. I mean, we've been very focused on the public sector. I think we need to begin to also focus on the private sector and quality within that. Because I'm just thinking about some of the initial analysis I've seen from the NFHS4, which shows, I think this is still preliminary, but what it's showing is that perinatal mortality is lowest in public facilities, and private facilities, it's even higher than where there are home births. And that is a little bit scary because we just don't know what is happening in private facilities. If we talk about standards in public facilities, at least we have the standards, whether providers are implementing those standards or performing as they should, we don't know. We know the gaps there. I think we haven't even started to deconstruct what happens in the private sector. We also seem to, I think there is at least some evidence to show that poor quality in the public sector are pushing patients, especially in cases of emergency, to go and get care in the private sector. It becomes imperative as that shift is happening to also then investigate that and look into it a little bit more.
So what you're saying is if this is a downward spiral of quality, can you turn it into a virtuous circle where, to what extent can the quality improvements in the public sector provide traction to the private sector? And one follow-up question is, are there inroads from the family planning side where private providers are being put in focus? So huge questions. Do we have, thank you Deepa. Do we?
One thing that struck me a few years ago was how limited continuing education was among doctors in India, whether public or private. And the question that I have, which I don't have answers for, is, actually I do have answers for, but I want to get into that, is essentially, what are the incentives for people to actually join these training programs? I don't even know if people attend these things, and if they do, whether they make use of those training programs at all in terms of their practices and so forth. Stop here.
Thank you. I'm thinking about that and your resource comment down there. I honestly believe that most people who go for a health service training, health education, they really want to do good. They want to save lives. And can you imagine how distressing it is to be out there and you're losing a woman, not only once, but every month you're losing a woman from bleeding or convulsions or a baby that you can't resuscitate. This makes you very elephant-skinned and very frustrated. How can we provide these resources to enable people to do these things that they are trained for and get them into an encouraging way that, hey, we can actually do something about some of these things we can do today? Do we have any, I hate to keep you too long, so I'm kind of around winding up, but dear distinguished panelists, do you have any final closure comments?
I have
Subrata.
one thing to mention. This is my own personal experience. When I was recruiting these nurses for nurse mentoring evaluation and RMC care, I realized one thing I asked in various nursing institute, how many deliveries you have conducted? So they are passing out. So some of them 1, 2, none. Now question to you is, because you do a lot of advocacy and also participate in those improvement in training curriculum program and all, I realized that some of the medical colleges where doctors are also really competing with the nurses to grab that they get experience of assisting deliveries or handling deliveries. In those competitive environment, nurse don't get any chance to assist deliveries. So where they will get experience. So this is a kind of my experience, and then you can think how this thing can be tackled in a different way or different situation.
So, having been involved in midwifery training and doctors training for many years, actually, I'd like to comment on this. 20 years ago, when in many, many countries, most births were at home, we didn't have the caseload, right? We couldn't do it. We had very few births, and this applied to many, many countries. Now we have the caseload, so now we have the possibility to have every birthing care provider, at least a nurse midwife, to do minimum 40 normal births and a few complications. That is minimum, and that's global. That's where I was in Mozambique in 1978, and it's the same number in Sweden, per chance. 50, 60, 70 births. That's what you do. You don't come out of school with a diploma having 15 deliveries under your belt. Forget it. And now we can do it. But yes, we have this issue that around colleges, all the sites are used up. There's a competition between medical students, between midwifery students, between doctors, OBGYNs in training. Everybody's fighting for those few. Then you have to organize shuttle services to the rural sites where you have all the births. You have to get it done. You have to fix it because we have the cases now which we didn't do 20 years ago. So let's get on with it. Final comments. Cassandra.
Just as we focus our efforts on where the numbers will make the most dent, we should also keep the leaving no one behind equity issues in perspective, and also measure and also look at the areas where the numbers may be small, but the rates of death are highest.
Thank you. The equity issue. And generally, we will find the highest mortality figures where it's most difficult to look. The most peripheral site with the poorest women. If you really study them in depth, that's where the highest mortalities are. Deepa and Ajay, did you have any final comments?
Again, going back to the fact that, these projects have been going on for a while, I really would like to know what are the kind of accountability measures that yield results. And I think we should not leave anything out. So we have incentives, we have disincentives. I think we also should not hesitate to have punitive measures when required. When deaths happen, let's use, all our quivers in in our bow, including going to courts to get remedies. Because I'm sorry, this has been going on so long, and we've given it a pass for so long, that I think, you have to use whatever is within your means to seek remedies.
Yes and no, in my view. We have a couple of African countries where if you report a maternal death from a facility, they put the doctor in jail. That's not very conducive to maternal death surveillance and response. So be careful. If the doctor is drunk or is raping the patient or killing a nurse, that is a court issue. But if the woman was very sick when she came and there was no mag sulfate and the nurse was sleeping on her watch, think through what was it behind these things and how can you learn and how can you be going on. So I'm not saying no, don't bring anybody to court, but be careful.
I think
don't bring all the doctors and providers to jail.
We do have public interest petitions where you can, public interest litigation, where you can bring issues that highlight gaps in the system,
right,
not individual providers. And you can get remedies. I think some of these things around, like, say, quality circle for family planning, all of that emerged out of public interest litigation. So let's not shy away in extreme cases from those sorts of remedies.
Thank you very much. Ajay.
Yes, sure. I just remember, just quote Mark Roberts, the now deceased. He said, every system is perfectly designed to observe the outcomes that you see. So in that sense, I'm a believer in the systems approach, not at the level of individual brilliance. I'll just stop here.
Thank you so much. Excuse me for being a bit bossy. I wanted to keep you awake at this time of day, and we have just touched on a few things that are hopefully going to keep you sleepless. We hope you go home and are sleepless with some of the issues, some of the concerns. Personally, I'm very encouraged. I think there's a lot of momentum. I was very happy to hear how Sridhar reported from Bihar that this has been really a stronghold of poor or non-existent quality, how it was like a cowshed 2011, 2013, if you remember. One of you reported, came up yesterday and said, well, we were doing one in-service training where a qualified provider showed a Pinard stethoscope and said, thanks for this training. I never knew what this was for. Now I know that I'm supposed to listen to the fetus during labor, and it's doing that. There's a lot of momentum. There's a lot of encouraging experience. I hope you go home encouraged, inspired, and also a bit sleepless. How can we push this on? Dear panelists, dear audience, thank you so much for this, taking part in this last session. Thank you.
So we didn't actually rehearse this part. We don't have a script.
Good. Good. You good.
All right. So thank you so much. Thank you so much for having taken the time, for having flown halfway around the world, or taking time out of the important work that you're doing in UP, Bihar, wherever you are, and joining this conversation. I for one have, I am inspired. I have been sleepless, and I think, there is so much work to be done. I think we have generated a really expansive, extensive research and innovation agenda. But I think it doesn't feel overwhelming, because I feel, here we are. We're almost 100 people. We were 100 people from yesterday, passionately discussing and debating this really important issue. So I feel extraordinarily privileged, actually, to also be in the position that I am, to help you all, to support you in taking forward this work. And the intent is to create a community of learners and a collaborative community, as we said yesterday morning. We do intend to pull the rich insights together, to summarize it, and to put a publication out, as well as a number of other products. We are working with Girija, sitting at that table, who's going to be helping us put these products together. But importantly, we're going to be coming back to you and requesting you to help shape the products that come out of this. So.
Yeah, no, I just wanted to say that I think the quality of the interaction here has been just so amazing, and it's really left all of us at a different, like at a much more elevated level. I think we've all fostered new connections and made new connections with the way we were thinking about our work previously. So I just want to thank everybody to help us all get to that next level of thinking. And our intention really is to kind of not keep this energy and momentum going. The products that we talk about are going to come pretty quickly. And of course, we are in a position where potentially we can also catalyze, but then we also have other donors in this group where there's possibilities to work together. There are other kinds of partnerships that with current resources that can be fostered. So there are different ways that we can start thinking about partnerships, which may not necessarily immediately need the additional resources, but they're just different ways in terms of co-publishing, co-ideating, writing a review or a synthesis piece. So I think that lots of things we should do, and we should do them to keep the momentum going. Both Sunita and I, for the last year that we've been at the foundation and working on these studies, have thought that quality of care is such an important platform to start bringing out some of the very critical issues. And it's really been validated here. Everything that we worry about, think about every day really came out, and the discussion starts. I mean, otherwise quality of care just seems like it's a mundane technical thing, but it's just helped all of us take it to the next level. And I want us to leave the room with that it's no longer just a technical, it is about respect, dignity, rights, and how do we really keep bringing that loop back into the work we do. So thank you so much. And that's it.
Support that Harminder, who I don't know if Harminder is actually in the room, but everyone knows Harminder. Yes. Must acknowledge Harminder and Navika, who's sitting there, who many of you have been in touch with. Navika is going to be following up because she's been cataloging a lot of information. She's going to be sending you a Dropbox link with resources from this meeting. I think, and Karima, who has also been involved in helping us brainstorm the agenda and pull the format together. So I think these are the three people that we've been leaning on. So thank you so much.